Hi, everybody. I guess we'll get started. It's just 2 o'clock. I'm Maureen Marcella from the New England QIN-QIO, and I'll be moderating today's webinar. Thank you for joining us today for improving clinical outcomes and unit culture through the development of Safety Attitude Questionnaire Action Plans. Before we get started, I'm going to quickly review a few of the housekeeping items. This call will be recorded for training purposes. I'll provide you with the details on accessing the recording at the end of the webinar. The phone lines will be on mute for the duration of the presentation. We will take questions at the end, and I will provide you instructions on how to unmute your line. We would like to encourage you to post questions during the chat into the chat feature. Make sure to send your messages to the all participant section on the chat area. We are unable to see things if you post them to all. So please, if you look on the right side of the screen, it says send to all participants. Please put it in there. At this time, I'd like to introduce our speaker, Margaret Vigorito. We've known Margaret for quite some time. She is a healthcare professional with over 36 years of experience in the field. She currently serves as a per diem consultant here at Health-Centric Advisors. But prior to her current position, she served as the Senior Manager of Human Resources here at Health-Centric Advisors, reporting to the CEO, and she worked on strategies with the organization to improve our goals. In addition, she was responsible for performing all the duties related to the human resources. Prior to her human resource position, Margaret served as the Senior Program Administrator, where she led the Rhode Island Intensive Care Unit Collaborative, which was a local and nationally recognized statewide initiative to improve patient safety and clinical outcomes. In addition, she was responsible for leading several successful CNS quality improvement initiatives, working with the stakeholders in both the hospital and the home health settings. Prior to joining Health-Centric Advisors, she was the Director of Medical Management at Neighborhood Health Plans of Rhode Island. In this capacity, she was responsible for setting vision and strategy and providing oversight for the case management, utilization management, and quality management programs. In addition, she was responsible for the development and management of medical and administrative expense budgets and identification of business and quality improvement opportunities. Throughout her 36-year career, Margaret has worked in a variety of health settings, most of which have been in the leadership role. She earned her bachelor's degree in nursing from Rhode Island College and her master's in science and health service administration from Salve Regina University. In addition, she holds the following certifications: CPHQ, Professional in Healthcare Resources, and Society of Human Resource Management Certification Professionals. Margaret, take the stage.
Hey, thank you, Maureen, and good afternoon, everyone. It's my pleasure to be participating in this program this afternoon. I'm really excited to share a local quality improvement success for which I served as project manager. Do I have the...
Yes, you do. You have the ball.
Okay, the slide's not advancing. Oh, there we go. Oh, wait a minute. It is advancing. Okay. So the Quality Improvement Initiative was a Rhode Island ICU collaborative, and today's presentation illustrates the link between unit safety culture and clinical outcome improvement. The findings of this were published in the Joint Commission Journal on Quality and Safety in 2011, and it's listed on the reference page at the end of the presentation, so I'll be sure to point that out to you at the end. It's my hope that after today's presentation, you'll walk away from the webinar with maybe some new ideas on how to translate some of the key concepts into your practice. So let's start by just reviewing our 3 simple objectives. First is to describe how conducting a staff debrief and discussion on unit safety culture results helps to inform the development of a Safety Attitude Questionnaire Action Plan. I'll use the acronym SAQAP because I know it's kind of a mouthful. Secondly, describe the impact that a documented unit SAQAP has on future Safety Attitude Questionnaire Survey results. And finally, to understand the impact of a unit SAQAP on CLABSI and athletes. Let me start by giving you a little bit of background on the ICU Collaborative. It all started in the fall of 2005 as a result of some informational discussions with our local congressmen and our local quality organizations. That led to us receiving some funding support from our commercial insurers in the state, and then we received commitment from hospital leaders to participate in the initiative. It was a partnership between our three quality organizations that you see here, including Health-Centered Advisors, we were at the time Quality Partners of Rhode Island, and Health-Centered Advisors served as the project management lead, and I served in that capacity. We were the first ICU collaborative in the country that had 100% participation of all of the ICUs in the state. We had 23 ICUs from 11 hospitals, and we were able to sustain that level of participation for 6 full years, which actually was, pretty impressive. So our goal was pretty straightforward. Okay, to improve patient safety and clinical outcomes for adult ICU patients through the development of a unit-based safety program and implementation of evidence-based practices. There were several components over the 6-year period of the initiative. So it all started in the fall of 2005, as I mentioned, and we started with the Comprehensive Unit-Based Safety Program, or CUP. And then we began to roll out our clinical bundle, starting with the CLABSI bundle, then the VAP bundle, and then we did the Surviving Sepsis campaign in 2008, and then finally in 2010, we did a palliative care initiative. So we did use the staggered approach, as you can see. So why did we start with CUP? Well, there's a strong correlation between teen perception of safety climate and clinical outcome performance, and this has been pretty well documented in the literature, and many of you probably have read about this. So it was really crucial that CUP was initiated before the clinical component to make sure that patient safety became the backbone of this initiative. I just wanted to pause for a second. I'm interested in finding out if your unit or if your facility has ever implemented a CUP program. So I'd like to just ask each participant to answer this polling question.
Here we have the polling question. You will have about 30 seconds to answer the question once it's posted, and it is up there. I see it now. After you select your answer, please click Submit at the bottom right-hand corner of the box. It takes about 30 seconds for us to get everything all told, so okay. Poll has ended. So I guess here we go. Okay, Margaret.
Okay. All right. So it looks like a number of you didn't answer, but 25 out of the 67 participants said no, and 13 said yes. So it sounds like so that kind of gives me a little bit of a sense of how familiar you are with CUP. And if you've not been involved in CUP implementation, I'm hoping that after today's presentation, it'll help you better understand the importance of CUP and quality improvement work. Okay. All right, I'm trying to advance.
It's not advancing.
You have to click back into the PowerPoint presentation and then hit the arrow or page up and page down on your keyboard.
Oh, there we go. Okay. Okay, so what is CUP? So it's a 6-step process to improve unit culture and safety climate, with the first and the last step being a safety culture assessment. So the safety culture assessment is really the basis of this talk today. So let's talk a little more about safety culture. It's important because it defines team attitudes, norms, and behaviors. Safety culture sets the tone for how does work get done around here on this unit, and therefore it has an impact on how people do or don't work well together and how they perform. It's an important ingredient not just in healthcare, but also in industry and team sports, and you probably have heard that term being referenced in those environments as well. So, being an avid cyclist, I'd like to draw a comparison to team cycling. Chris Fromm, who was a professional cyclist and former Tour de France winner, he once stated that in sport, you always think the strongest guy should be going for it and getting the best results. The thing is, cycling also has a very important team aspect, which I don't think a lot of people fully grasp. So in cycling, members of a team, they ride in a peloton to maximize their efficiency and their performance. Without the support of the peloton, Chris wouldn't have been able to win the tour. And the same thing is true for us in our teams as we work to deliver quality patient care on our unit. So safety culture really does provide the framework for all of our improvement work. And the road to improvement is really a continuous journey. It's not a destination. So, you can really give some thought as to whether or not you think your colleagues fully grasp the importance of teamwork in the delivery of patient care. If a team fails to work well together or they don't communicate clearly, there's a much greater risk of a bad outcome, just like in cycling. If the team is not well coordinated, if they're not being efficient and speaking to one another, you can have a bad crash and a bad outcome. So for our safety culture assessment, remember the first and the last steps of CUS, we use what we call the Safety Attitude Questionnaire. Some of you may have heard of this tool. We refer to it as the FAQ. So this is a frontline caregiver's assessment of patient safety across 6 domains. The tool is valid and reliable, and it is responsive to interventions. Many of you may have heard of Brian Sexton. Brian developed this tool when he was at the University of Texas. He's currently director of patient safety at Duke University. And many of you know he's a national expert in that topic, and he's published extensively on patient safety as well. He also participated in the safety culture education with the ICU Collaborative. We were really very happy to have him participate with us. And he was also a co-author of this publication, which is the basis of this talk today. So we conducted our baseline SAQ in the fall of 2005 when the ICU Collaborative was launched. Again, all of the 23 ICUs participated in that. And then it was re-administered every year in the fall after that. So another polling question. I'm interested in finding out if your unit or facility administer a safety culture survey at least annually. So let's stop again briefly to answer this polling question, and it's just a yes or no on your screen.
Of yours, polling up at the top.
Emily or Jennifer, could you please open the polling question? Thank you.
There we go. So again, it will take 30 seconds to answer the question, and once it's finished, it takes a few minutes to populate the results. So go ahead and answer. Does your unit or facility administer a safety culture survey at least annually? And it should, I think it ended. It should be up momentarily. Oh, no, I think it's got one remaining second, it looks like. Here we go.
go.
Results.
Okay, so this one is about half and half. Okay. I guess I thought it would have been more than that because it's not a joint commission recommendation.
It's a suggestion, and maybe you misunderstood. We probably should have said that for some facilities, it's an employee satisfaction survey, which has the same questions, very similar, because we did that. A lot of places use the OP survey.
Okay. All right. So this concept may or may not be familiar to you, but I know a lot of hospitals are now administering an annual survey to their staff. If you're not doing that, that's something that you might want to consider. Okay. So moving on to the SAQAP, which is the Safety Attitude Questionnaire Action Plan. It is a documented plan of action identifying culture improvement opportunities and interventions based on a unit SAQ result. So, after a few years of leading this project and administering the SAQ survey, I began to develop a hunch that units who acted on their results and they documented an improvement plan would demonstrate higher rates of improvement in safety culture and clinical outcomes the following year. So after the 2008 survey, we set out to study whether or not there was any truth in that hypothesis. The aims were twofold: to analyze the impact of the SAQAP on the 2008 SAQ survey results compared to the 2007 survey results across the 6 safety domains, and secondly, to determine the impact of the SAQAP on the 2008 CLABSI and VAC rates compared to the 2007 CLABSI and VAC rates. As far as the methods, as I already mentioned, the SAQ was the tool that was used to assess the frontline caregivers' perception of patient safety. All multidisciplinary team members were invited to complete the survey, and the tool was administered annually by Pascal Metric Health Bench. And again, looking at 2007 and 2008 with all of our 23 ICUs. The SAQ included 6 domains. The domains were teamwork, safety climate, perceptions of management, work conditions, job satisfaction, and stress recognition. Each of those domains had a series of questions that correlate to that specific domain. 64 questions in total, and those questions use a 5-point Likert scale ranging from disagree strongly to agree strongly. The individual responses were aggregated by clinical area and then provided a snapshot of that unit's climate across each of the domains. Overall climate scores, anything that was 60% or more was considered favorable, the goal being 80%. And if you had any improvement of 10 percentage points or more from one year to the next, that was considered significant for your unit. As far as the BSI and that data was collected by each ICU team and submitted monthly, and that was put into a web-based data collection tool. That data was able to be trended monthly, quarterly, and annually. And for this study, the 2007 and 2008 annual mean rates were used and reported for 1,000 line days and 1,000 ventilator days. So after the 2007 results came in, teams were urged to conduct a more formal review process with their teams, and then they were asked to develop and document their improvement plan using a SAQAP. I met with many of the ICU leaders, provided them with additional guidance and education on how to analyze the results and how to lead team discussions. We provided them with some educational programs and learning sessions. Again, being a small state in Rhode Island, we were very lucky that I had the capacity to do face-to-face on-site meetings at their facilities. All the hospitals were provided with a SAQ improvement toolkit. The toolkit included things such as how to conduct a unit debriefing session using a culture checkup tool. The culture checkup tool is a tool that, again, was developed by Brian Sexton, and at the end of the presentation, you'll see there's a reference to a publication on the culture checkup tool. And basically, the tool provides a framework to review and discuss the results with your team, particularly in areas where you may have scored a low score. And then finally, they were provided with a template for which they could document their plan. And they were given the freedom to use whatever vehicle they wanted to document that, but we did provide them with a template. And then finally, I developed a survey to track whether or not people actually did develop their action plan for their unit. This is just a very an example of the template that I provided them with. Again, very, very simple, straightforward work plan, and most of them did use this tool, or the ones that did use it. The statistical significance between groups was calculated using the student's t-test as a significance value of p less than 0.1 because of the small number of units, and the p-value compared change from the 2007 to 2008. We consistently boasted a high response rate on the SAQ survey every single year, and as you can see here, in 2007 it was 82%. And in 2008, it was 85%. Of the all multidisciplinary team members who had been working on that unit at least 50% of their scheduled time and had been working on that ICU for at least 4 weeks or more before the survey were invited to participate in the survey. The majority of the respondents were nurses, female, white, and employed from 2 to 5 years. And there was no significant difference in the respondents between the 2 years. So as we discuss the results, I'm going to break it down into the 2 groups. First, we'll talk about those units that actually did develop an SAQAP. So remember, let me remind you, this was a strong suggestion that they do it. It wasn't mandatory. All of the participation with this ICU collaborative was voluntary. So although they were urged to do it, not everyone did. And so as you can see here, there were 9 out of the 23 units, so 39%, that actually did develop an SAQAP. So we're going to talk about that group first. So of those 9 units, their median response rate was 83%, which is really in line with the overall response rate that we had. The other thing that was interesting about this group was that their staff appeared to have older and more experienced staff. They also had higher rates of physician participation, and they also had a more balanced representation of respondents across all the shifts. Excuse me. The 9 units that developed the SAQAP demonstrated higher rates of safety culture improvement from 2007 to 2008 in all 6 domains with the exception of working conditions. And the improvements were close to significant for teamwork, climate, and job satisfaction. And during that same study period, higher rates of clinical outcomes were also seen. So as you can see here, they had a 10.2% decrease in the BSI rate and a 15.2% decrease in their DAC rate. And that was just in 1 year. Now we're looking at the units that did not develop action plans, so that's the remaining 14. Similar response rate, once again, 83%. They had higher safety culture scores in 2 out of the 6 domains, and as you had seen in the earlier slides, those with the plan had improved in 5 out of the 6. These units decreased their BSI rates at a much lower rate, 2.2%, as compared to the 10.2% decrease you saw on units that did have a plan. And they actually went up in their DAC rates by 4.8%, where the other group went down by 15.2%. So that's a big difference. This table summarizes the raw SAQ data for both 2007 and 2008 by domain scores for the units with and without a action plan, and also the relative rate of improvement for each of those. So as you can see, the units with a SAQ-AP improved in 5 of the domains, and you can see that in the green under the relative rate of improvement. 3 of those domains, you'll see, are in the double digits. And again, teamwork and job satisfaction were the only 2 that were significant, but perceptions of management was also pretty high at 20.2%. And then the units with the SAQ improved in fewer domains and to much less extent, as you can see. This is a bar chart that I think just provides a better visual illustration of the differences between the 2, the blue bar being those units that have an SAQ with the higher bars, obviously. Now moving on to the clinical outcomes. This table summarizes the raw clinical data for both of those years again, separated by those with a plan, those without a plan, and you can see clearly the differences in the improvement rates between the 2. Although neither one of these were considered significant, and more than likely due to the fact that we did have a small sample size. And then this is just the graph illustration of the same data, and you can see the much greater reduction in the infection rates for those units who had a plan. So as far as the strengths of this, one of the strengths of the study was the sustained participation of 100% of the ICUs in Rhode Island, and that we've had high response rate. And it wasn't just during the study period that we saw this, but it was through all 6 years of collaborative. Also, the small geographic size of Rhode Island really helped to support a very high-touch project management approach that entails on-site consultation visits and the ability to bring people together face-to-face for team leader meetings and for learning sessions. However, there were also some limitations that we recognized. First, we didn't evaluate the extent to which the ICUs or particular caregiver types implemented those interventions that they identified, or the level of staff participation in the development of the action plan. So some of the variations in the safety culture improvement could be due to variation in implementing interventions. Secondly, even though we had 23 units that were encouraged to develop an action plan and debriefing, there were only 9 units, as I mentioned, that completed the process, so that potentially resulting in self-selection bias. And then finally, the generalization of these results to non-ICU units is not known. And then I already mentioned about the sample size being small, and there's definitely a benefit to being in a small state because of that nice high-touch approach and really being able to build relationships and rapport with those people at the front line. However, the small state size can also be a detriment in that the small sample size restricted the power to detect the differences that were statistically significant. So this was the first study of its kind that demonstrated the relationship of having an SAQAP to improving culture and clinical outcomes. Many QI cohorts failed to identify and understand the variability that exists between their overall improvement efforts. But most importantly, it's pretty clear that those people who plan often do better. There's a typo on the slide, I apologize. So in summary, teams that developed a Safety Attitude Questionnaire Action Plan not only had close to significant improvements in unit culture, but also improved in CLABSI and VAP clinical outcomes. So you can probably, again, apply this to other clinical improvement projects. I know many of you are working on other HAI initiatives, and so I strongly feel that the same would be true for other areas of clinical improvement. So it could be using an action plan, a safety attitude questionnaire action plan as a result of your culture results can be an effective way to improve your unit culture and clinical outcomes on your unit. So what happened after this study period? Well, as I said, this continued on till 2012. We actually did the annual survey through 2010, because after that we lost some of our funding. There was some funding that we had received, and it gave us money to administer the survey. But through 2010, I can tell you what had happened in that we were able to share the results of our finding broadly with all of the ICU teams. We did this formally and informally at learning sessions, at face-to-face meetings, and that really led to a lot of engagement. It really got people's attention. And so what we saw was the following year, in the spring of 2009, teams were surveyed again to find out who actually completed a plan, and we had 18 out of the 23 ICUs who reported that they documented and implemented their action plans in response to their 2008 results. And then the other thing is that the 2009 SAQs, the state aggregate improvement rate in 4 out of 6 domains had improved significantly, with improvement ranges that were between 16 and 21 percentage points. And earlier in my presentation, I said 10 percentage points or more improvement in any one domain was considered significant. And so here we were seeing significant improvement statewide in 4 out of those 6 domains in 2009. And then in addition, for the first time since 2005, the state achieved, again, the state aggregate scores reached overall performance levels that were considered out of the danger zone, or over 60 percentage points in 4 out of the 6 domains. Further sustainability was demonstrated with the results in 2010, and at that point, it seems that the SAQAP development had become a standard practice across most of those units. So this is a reference list, and the reference list includes the study article that was published in the Joint Commission Journal on Quality and Patient Safety. That's the one that's down at the bottom, that's highlighted in red for those of you who want to reference it. Secondly, it includes the other article that I mentioned to you by Brian Sexton on a culture checkup tool, and that's the second listing here on the reference list. So you might want to follow up on those if you're interested. And then finally, I've also included a resource page. Many of you know there's a number of free resources and tools on the web that you can access to help guide you in your facilities with your safety culture work. I've included that here for you as an easy reference. And then finally, remember, continuous improvement is a journey, and we all need to work together as a team in order to achieve those results. Questions?
Thank you, Margaret. At this time, we will take a few questions. If you would like to ask a question, please press *6 on your phone to unmute your line. You can also post additional questions in chat, but remember to share it in the All Participants square at the right-hand side of the screen.
Maureen, I actually have to hit a few commands to allow people to use that feature on the phone, so bear with me just a minute while I turn off lecture mode.
Okay.
while Morgan's doing that, I just wanted to make another comment. One of the things that I had mentioned about the units that had developed an action plan that they had improved in 5 out of the 6 domains. The one domain that they did not improve in from 2007 to 2008 was in working conditions. And although I really can't, I don't know for sure why that was, but I can certainly speculate. And again, I think one of the advantages of having had such a close relationship with these teams and really getting to know them is that I also knew a lot of the nuance that were going on in the unit. And for those of you who have been in healthcare for a while might have remembered that back around that time, around 2007, 2006, there were high turnover rates in the hospitals. And Rhode Island was not, we experienced similar issues with the turnover, not just frontline, but leadership turnover, a lot of leadership turnover in 2006 and 2007. And so my speculation is that the high turnover in leadership during that time period really did impact how people felt about the working conditions. What happened after 2008 was that there was some stabilization that happened amongst our unit. I remember at one point actually quantifying the amount of turnover just in the unit ICU managers and the ICU directors during that time. And I don't remember the exact percentage, but I know it was more than half of them who had lost either an ICU director or an ICU unit manager. So I can't underemphasize how important leadership is in all of this.
And it looks like we have 2 questions for you, Margaret. The first one is, are you a serious biker?
And the answer to that is yes. I was just telling Maureen I'm leaving tonight to go to North Carolina on a cycling tour.
Yeah, she's a very serious biker. Got hit several times by automobiles, so yes, she's an extremely serious biker. The second question is, why did you wait till 2006 to have the seminar? I can answer part of it for you. This particular seminar, we have had some of it in Rhode Island. We did it now because now we're the region, and I don't recognize your name here, so I'm guessing you're from one of the other New England states. So I guess that was probably the reason. Margaret, anything to add to that?
The question was, why did we wait till 2016?
Oh, 2000. Many years. Yeah. Oh, yeah. Did I say 2006? I'm sorry. Why did we wait till 2016 to have the seminar?
Yes. I can say that a lot of this has been showcased locally in Rhode Island, and some of this has actually been showcased nationally. Like this publication was in the Joint Commission Journal, so that's in the public domain. So it's not like we haven't shared this information. It also was a presentation at the annual IHI conference in 2010. 2009 or 2010, we presented it at the IHI conference. And we've done other presentations as well on the ICU Collaborative, but we have not done it with the QIN-QIO until now.
Thank you. Thank you, Linda. Any other questions? Okay, I have one for you, Margaret. What would you say is the most critical aspect for success of this initiative?
I think like any quality improvement initiative, you need leadership support from the top down. And again, this is anecdotally, I can tell you that the hospitals or the facilities where I felt that the executive leadership team was very engaged in this initiative were also the ICU units that had the highest rates of performance. And then the local leadership was just as important. I already mentioned to you about the turnover rates and what had happened in 2007 2008 and how that impacts unit safety culture, that lack of stability, new people coming in, maybe not getting a good orientation. But I would say leadership, overall leadership both at the local and the executive level.
Any other questions out there from the audience? Okay, one other question, Margaret. Is there any, or actually to the group out there, is there any participant on the call today that routinely trends or correlates unit or facility safety culture scores with the clinical outcomes? And if so, can you share your experience? And it looks like there was 13% of you in that first polling that did some sort of a questionnaire to your staff. Is there anyone that can answer that? No? Have to pound 6 to unmute your line if you do have a question. Okay, I have another question. It's not really a question. I guess it is a question for you, Margaret. It says, I would love to learn more about the action plans and the journey each unit took to lower their infection rates. Is there another place I can read up more about this?
If you access the actual journal article that I referenced on the reference page that was in the Joint Commission Journal that we wrote up, there's actually a sample action plan that it might have a couple of things on, a couple of interventions on it that one hospital, from one of the hospitals. Beyond that, I would say if you'd like to contact Maureen offline, and she could probably put you in touch with any of the ICUs who participated who were high performers. I can give her that information, and perhaps they'll be willing to speak with you, because, yeah, I agree that that is how we learn, is by seeing what other people do. So that might be an opportunity. So I would say get in touch offline with Maureen.
Yep, that's fine. One thing I can say, because in my previous life I was part of this ICU collaborative, and one of the things that we did at the facility I worked at, there was, as you all may know, when you try to do a survey of employee satisfaction or any type of a survey, you never get good rates, and we got unbelievable rates in the 83 percentile. And one of the things was you were running around to all your ICU people, at least that's what I was doing, and it was very difficult to get that done, but I was persistent in getting them, and it looked as though everyone who was probably in charge of getting that done. And we, in those days, back in 2006 and 7 and 5, we had to do, it was a paper tool. It wasn't we had to fill it out like the old SATs. I thought of that. It was just like that, filling out a grid. And then putting it in an individual envelope so it would be secure and no one would know what you wrote. And so that was I can say that was a lot of work, but it was beneficial because when we looked at the scores, we knew that we had the majority of the people voicing their opinion of what was going on in the individual unit. And that was great. Any other questions? You can pound 6 to unmute the lines and ask the question.
Even if you don't have a question, if somebody has something to share, maybe you've done something similar where you've been able to correlate some safety culture work with some of your clinical outcome work, or something innovative that you may have done that you might want to share with the group.
Okay, then rather than hold you up, I'm going to continue out. I want to thank Margaret for the presentation, and I want to thank all of you for listening in today. I just have a few last announcements before we end the call for today. When you close out of this webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate having that information. If you don't have time to fill out the evaluation right now, or you are currently sharing this computer with someone else, you will receive an email tomorrow morning with a link to the evaluation, as well as a link to the event page on our website. The PowerPoint presentation is posted on our website, and within the next few business days, a recording and transcript will be added to that. Be on the lookout for emails about our next webinar in May. I believe in May we're going to be going over the spring NHSN newsletter. Again, thank you so much for attending, and have a great day. Bye-bye, everybody.